Welcome everyone to today's webinar. I'm Emily Rapley, Managing Editor of Becker's Hospital Review. We will begin today's webinar with a presentation and we'll have time at the end of the hour for audience questions. You may submit your questions throughout the webinar by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We look forward to hearing your questions. Additionally, in about 1 week following the webinar, we will be sending you a copy of the presentation to the email you used to register. At this time, it is now my pleasure to start today's webinar by introducing our presenters. First, I would like to introduce Dr. Bonnie Bart-Malio. Dr. Bart-Malio is a Managing Director with Prism Healthcare Partners, a national healthcare consulting firm. She has over 35 years of healthcare experience with extensive expertise in effective delivery of patient care, resource management, operations, and planning. Dr. Bart-Malio's deep clinical and operations background includes administrative and clinical positions at providers including community and specialty hospitals, as well as academic medical centers. As a consultant, Dr. Bart-Malio assists healthcare organizations in designing and implementing processes to deliver quality patient care through efficient resource utilization. Barbara Bryan is Managing Director with Prism Healthcare Partners. For more than 20 years, she has guided hospitals, health systems, and academic medical centers through comprehensive clinical performance improvement initiatives. Barbara specializes in process improvement, patient flow, management tool development, and critical analysis of potential improvements in cost, quality, and service. She has developed service lines and methodologies for patient throughput and capacity management and is frequently asked to share her knowledge through articles and presentations for distinguished industry associations and publications. Today, Bonnie and Barbara will discuss patient throughput, highlighting the effects of inefficient patient flow within a healthcare organization, as well as the steps hospital leaders can take to proactively address patient throughput issues, ultimately improving bed capacity, patient satisfaction, length of stay, and emergency department wait times. I'll now turn the floor over to Barbara to kick off our discussion. Barbara, how significant of a problem is patient throughput, and what are the real costs?
Thank you, Emily. And on behalf of Prism Healthcare Partners, Bonnie and I would like to thank everyone who is joining us for the session today. Patient throughput is a problem that we see consistently throughout the country at all types and sizes of hospitals, from large academic medical centers to small community hospitals. These patient throughput issues have been brought into focus not only because of the inability of hospitals to effectively accommodate patients, but also because of regulatory standards that are enforcing effective patient throughput. For example, the CMS star rating system has indicators based on ED throughput time, such as door to diagnostic evaluation from a medical provider. These types of indicators will contribute to hospital star ratings. Another factor that creates a burning platform are the Joint Commission standards, as you will see on the next slide. Here's a brief synopsis of these standards. First, there's a focus on establishing processes, measures, and goals that support patient flow. Secondly, plans to care for patients who are in alternative locations, patients that are boarding in your EDs, in your PACUs, perhaps in hallway beds or other overflow areas, with a particular emphasis on behavioral health patients. You must have criteria for ambulance diversion. And what I think is most important is active review of processes and taking action to improve when goals are not achieved. So you're not just looking at patient flow at your organization, but what are you doing to change it is going to be very important to meet these standards. To address the second part of the question that Emily asked, what are the real costs of ineffective throughput? Let's move to the next slide. When you look at the financial benefit related to throughput, we look at the cost associated with keeping patients in the hospital longer than necessary. You start by comparing your patient population average length of stay to the established geometric mean length of stay to determine an estimate number of days that patients are staying beyond the geometric mean. Applying an industry average cost of about $450 per day, you can estimate the financial impact of ineffective throughput. So as you decrease the number of days that patient stays, this decreases the cost, but also allows for additional capacity. So in this example, for this client, who is a trauma center in the Midwest, If they were able to decrease all of their excess days, they could create 73 beds and have a financial impact of nearly $12 million. Of course, we all know that that is unrealistic. You'll never reduce every single excess day. With most hospitals where we've worked, we see improvement range anywhere from 20 up to 50%, but in most cases, a successful patient throughput project yields about 25% improvement. So for this hospital, decreasing excess days by 25% will open 18 beds and creates extra capacity. And the question becomes then, what do you do with that additional capacity? On the next slide, Bonnie will explain how to address that newly created capacity.
Thank you, Barbara. There are two strategies for managing the capacity shift, which depends upon the individual hospital situation. The first strategy is if you're fortunate enough to have volume to fill the beds, there's a great revenue opportunity. Those additional beds may relieve constricted services or even develop new service offerings. For example, one hospital that we worked with used the extra beds to add capacity to a cardiac service, which was part of their strategic plan for growth. A second strategy is to maximize and reevaluate resources needed to care for now a smaller patient volume on a daily basis. Strategies in this scenario include reworking staffing plans to correspond with the lower volume, review the ancillary service hours and services to assure that they provide the necessary services and don't serve as a barrier to discharge, but that they're strategically offered in order to be more efficient. Also, it's a good time to rethink the configuration of the patient care units for greater efficiency. It may be useful to close a unit and open it only when volume indicates it's needed. Other options include converting semi-private rooms to private rooms or to create a dedicated observation unit to manage those patients with greater focus. Emily, we can proceed to the next slide.
Thanks, Bonnie. So what are some common misconceptions about patient flow and throughput?
Emily, let's proceed to the next slide so I can answer that question. The number one misconception around patient throughput is that it can easily be solved and it can be done quickly with just a few changes, or that nursing and case management together can resolve this on their own. When in reality, it's a long process, usually 6 months to a year, that requires whole system change and dedicated interdisciplinary participation. The chart that we have here before us demonstrates at a high level the interrelationship of people and processes to make this work and the essential role of consistent, constant communication to a level that is probably not present in the organization. Next slide, please, Emily. Taking this point just a bit further, the diagram on the left is a typical picture of what we see as a communication flow for patient transition and discharge during an assessment. The chaotic, almost spaghetti-like communication patterns make communication cumbersome, time-consuming, and overall ineffective. Almost like the child's game of telephone is what we'll see on the left. For example, it's really not unusual for us to observe that the hospitals will call each of the case managers individually every day, usually in the morning sometime, so that they can, and if that doesn't happen, then the case managers call them early in the morning to make a plan for the day and to discuss discharge barriers. So between them, they each may make a half dozen calls, each to discuss the same thing. And then they both have to discuss this with the charge nurse and the primary nurse, and the message gets jumbled. What we like to see is more on the right of your diagram is that shows a consolidated team working together with a focus on the conversation around the patient, using a well thought out script around the plan of care, discharge barriers, and how the patient is actually transitioning. Focused daily discharge rounds aligns all who deliver care in one conversation, resulting in a synchronized plan of care that addresses both the care issues and the discharge barriers. Emily, we can progress to the next slide, please. Another common misconception about throughput is that it begins in the ED. We argue that the ED is the victim of poor throughput rather than the source, since they are dependent on beds available in the inpatient areas to move patients through the ED. Effective patient throughput starts with effective discharge processes, which may seem a bit backwards, but it is the best way to manage beds and make them available for incoming patients as quickly as possible. So you'll see in this diagram the two main activities on the left under the discharge planning and discharge execution. Targeting the anticipated day of discharge and then transitioning that patient and progressing their care as efficiently as possible leads to an effective day of discharge processing. We routinely look for discharge orders written before noon and nurse processing of discharge patients in less than 2 hours. An hour and a half is even better, but 2 hours is sufficient. Creating open beds in the inpatient area is the best way to maximize ED throughput. Discharge processing can be also supported by the interdisciplinary discharge rounds we discussed earlier, daily huddles that discuss planned or potential discharges, and visual cueing, either electronic or a whiteboard that provides and displays the discharge information is useful. Visual boards in particular can help everyone from the clinical staff to support staff to prioritize their work around the discharging patient. On the right side, we'll see effective bed management processes, and we think of those in terms of protocols for rapid patient placement and systems to prioritize clean bed cleans is essential. It's also extremely helpful to align the discharges with the housekeeper's schedule to assure there are adequate personnel available to address vacant beds. Often the housekeeping schedule is such that the staff is ending their workday just as the beds are becoming available for cleaning. And then foundational to the entire process is measurement and communication of key metrics of outcomes as well as processing. Measurement holds everyone accountable through the publication of the progress. It also supports change and targeted change when necessary. When those numbers are slipping, it allows us to target into what seems to be the problem and make quick corrective action. Emily, you can progress the slide, please.
Thank you, Bonnie. So keeping some of those misconceptions in mind, Barbara, how do you start a successful throughput improvement project, and what are some critical success factors?
Those are both very important questions. And if you flip to the next slide, Emily, this is how you can begin to structure really a successful throughput project for your organization. So step number one is really to establish a sound project infrastructure. So if you look on the slide from the bottom up, those are the foundational components of building your infrastructure. So first is to determine an executive sponsor who has the authority to drive an organization-wide effort, which is what a throughput project really requires. Messaging and communication from the executive level will be very, very important. Secondly, is to establish committees and work groups with interdisciplinary membership. You must have leadership, frontline representation of people who really understand the work and do the processes every day, and of course, physicians. I think it probably wouldn't be a surprise to most people on the call today that physicians are so important, and they can, in fact, make or break a successful throughput project. So it's very important to involve them in each of the work groups from the very beginning. Third is to establish goals, expectations, and project ground rules. So examples are how often the project team should meet, the expectations related to reporting progress, and some ground rules such as open and honest sharing of ideas. So everybody who's involved in the work group, no matter what their position is in the hospital or organization, has a voice and is important. Next, establish a project timeline. A patient throughput project is very large and it's easy to get overwhelmed with the work that's going to be involved. So you must establish a reasonable timeline with milestones. A good range would be about 6 to 12 months, depending on the size of your hospital and the complexity of your throughput problems. Lastly, a solid communication plan should be established. So you should communicate often, and you should communicate in many methods. So some examples would be town hall meetings, newsletters, huddles on the inpatient units, or communication boards in key areas of the hospital. All of these are great ways to communicate the progress of your throughput project. And we can move to the next slide. So after you establish a sound infrastructure, then you need to set up some other critical success factors for a throughput project. First is thoroughly examining your key processes. You need to understand your current state so you can determine future state. So an example would be flow your patients through all your portals of entry, through your ED, your direct admission, procedural patients that require inpatient beds, and also flow the patient's discharge processes and all the complexities that go along with those processes, from physician order to when the patient exits the building. Next is to establish meaningful performance metrics and methods of measurement. If you can't measure it, you can't manage it. So you need a baseline on which to measure your progress. We'll talk more about metrics and how to establish those in the next few sections. Tools and technology will be key for your throughput project. You need to understand what technology you have and how it can help you. And if you don't have sophisticated technology, you could use something as simple as a visual cueing board on the nursing unit. And lastly, communication cannot be emphasized enough. It's important to communicate the results of the project in many methods and often. So those are the critical success factors to a patient throughput project. Emily, you can move to the next slide.
Thanks so much, Barbara. I'm really interested in talking about, you said clinicians can make or break a project. Bonnie, how do you engage at all levels, from management to medical staff, in managing and improving throughput?
It's a great question, Emily. Let's progress to the next slide and start to answer that. Gaining engagement begins with a sound decision-making structure that really begins at the top, and that decision-making structure holds the process together and holds everyone accountable to follow through and achieve the goal of patient throughput. The oversight committee, you'll see at the top of the slide, is comprised of really high-level executives that oversee the project at a much more overview level rather than in the trenches, so to speak. Sometimes it can be the whole entire senior leadership team, and the throughput committees will report to them directly with their status, their outcomes, and what kind of things are next on their plans, next on their horizon. The patient flow steering committee is the next box down, and that is led by a senior executive, and it's usually either the chief nursing officer, the chief medical officer, or the executive responsible for case management, or a combination of any of those three. Membership is usually limited to a small group of leaders that are have responsibility that's directly involved in this area. This group is the decision-making group, and it works to get barriers and boulders out of the road to affect change rapidly. The real purpose of this group, or key purpose of this group, is to mentor the work teams and make quick decisions to keep the process going. Now, the work teams are formed to follow the patient, so to speak, from the entry into the organization for an admission, and then aligns processes by getting into the minute details, and determining the tools, people, processes, and necessary for support and good throughput. So when getting the clinicians involved is really at the level of managing that patient right through the processes. And it's not just clinicians, it's people in access, patient access, revenue cycle, patient communication, telecommunications. So it includes pretty much everyone in the organization. Emily, we can progress to the next slide. Okay, so this gives a little bit deeper dive here on how this all really works. This diagram illustrates interactions among the teams kind of at the work level of really getting planning and processing and implementation completed. The steering committee really meets weekly, usually for 30 minutes to an hour, to review the work group's activities and progress. And that's that group we were talking about before. That is the CMO, CNO, this decision-making group. These meetings really are meant to discuss the barriers that they can influence, areas of additional support or guidance, and then offer advice that makes the work group's progress go as quickly as possible and as smoothly as possible. The work team meetings and the next group are also held weekly. And we often will hear, let's not do weekly, let's do every other week. But that weekly meetings tend to keep the momentum moving to make change rapidly. Activities include developing and implementing plans for improvement, tracking results, determining necessary course corrections by reviewing that data weekly, seeing how things went in some of the pilots we're going to talk about in a moment, and then communicating to other teams. Pilots are used often to test actions for improvement. And they may be small. In fact, we prefer, especially at the beginning, for them to be small, but they provide a testing ground for proof of concept. Pilots also are expanded until it becomes hardwired in the organization as part of the communication and provide another avenue for others to participate, those that may not be specifically on the committees, but allow others to participate, contribute, and problem solve along the processes. For example, one hospital we worked with was experiencing a real delay in getting telemetry patients admitted from the emergency room to one of the telemetry units. Since at the time, both of their telemetry units were semi-private rooms, and so this often required 2 or 3 bed transfers to get the patient up, and it was a major throughput delay. So they did a pilot where 2 of the telemetry units were then made gender specific. So there was 1 male and 1 female telemetry unit. The transfer time was then cut in half, and the pilot was expanded until it became hardwired for the organization as part of the everyday way of managing those 2 units. Active problem solving, as in this case, is key to this pilot's success, and it supports continual hardwiring into the organization and spawns other pilots for testing and to create new processes. Emily, I'm sorry, next slide, please. Thank you. Some of our critical success factors for the committees and work teams include starting with communication. And we can't emphasize in this presentation communication enough, because you cannot over communicate in these days, in these particular situations. However, almost equal is the visible and vigorous support of the very senior leaders. They are included in the leadership structure, but they also demonstrate their support through rounds, especially in those pilot areas, asking questions when they go on those rounds of those participating. Being conversant on the data and outcomes and the process of where the project is, discussing in town meetings, prioritizing this as a topic for discussion in town meetings, and even publishing in the employee newsletters or other methods that they use for communications. All of these actions communicate that it is an important aspect in this organization, and that we're going to keep putting time and energy towards a positive completion. Now, there's bound to be disagreements, and so constructive criticism and problem resolution, it must occur, it has to occur. And this can bring up topics that have been long buried, frustrations, or perceived inequities that can rise to the surface. On more than one occasion, we've had very vigorous, sometimes even heated debates over the ED wait times and the role of the physicians, hospitalist responsiveness, and other team members' accountability for facilitating discharges or patient transfers. During the process, the roles get changed and productivity can be reestablished or questioned, and strong negotiation is in order. Sometimes it'll take several meetings to come to agreement as to what the next steps are and to start putting some of the past behind us and move forward into our new system. Commitment of time and in some cases resources can be extensive. As we said earlier, this is a heavy lift involving the roles and relationships of many individuals and whole departments. So it's not unusual to implement, for example, new electronic tools or create new roles or a number of other support systems to make throughput much more smooth than it is operating now. But this is also an added expense that we need to address. Balance prioritization with other needs and efforts in an organization is an ongoing discussion. You know, throughput and what we're talking about today to us is a priority, but every hospital has many other priorities and many other projects that they are working on to keep progressing. So we would say that at continuing to discuss it, to make a plan that's at your pace in order to implement this is important to make sure that those priorities last. And then holding stakeholders accountable to attend meetings and follow through on tasks is imperative. That's aided by having weekly meetings, so someone has to come back and it doesn't get lost in the activities of 2 weeks or a month. A weekly meeting really helps that. And this includes senior leadership in this, that they follow through and they come supply answers or the support that's needed. Emily, you can progress to the next slide, please.
Thank you, Bonnie. So as Bonnie mentioned, once management and physicians are involved and engaged and the patient throughput improvement initiative is underway, Barbara, how can hospital leaders track and manage clinical performance throughout the day, the week, and the month?
Thanks, Emily. We talked earlier about the importance of performance metrics along with tracking and reporting this information, but some metrics will only be able to be measured monthly, while others can be measured daily or weekly. So we outline these factors that are important when establishing metrics and measurement methods. So as you see on this slide here, there's really 4 important components to remember when you're establishing your performance metrics, and that is that you keep them measurable, simple for everyone to understand, they're meaningful to the process, and that they're timely, so you're not waiting a long time for the information to know how you're progressing. So you need to really tie specific metrics directly to the initiatives that you're putting in place. So Bonnie had mentioned earlier a pilot about the telemetry beds and the movement of those patients. Putting a metric that is very specific to perhaps how long it takes for those telemetry patients to move in a baseline compared to after the pilot would be very important to know. Secondly, is you need to determine your data sources and validate the data integrity. This is something I want to emphasize the most on this slide, because the data integrity will drive the success and the buy-in of the physicians. Physicians are very data-driven, which is great, but they need to understand where the data came from, and they need to believe that the data is accurate. So make sure that when you determine where that data is coming from, that you really validate it thoroughly to ensure that it is correct. Establishing goals and baseline, we talked about. Communication system, so everyone understands how to share the information to everybody. The ongoing compliance and monitoring. Bonnie had talked about accountability in the previous section. You need to set up standards to make sure everybody knows when the performance metrics will be measured and managed. That way everybody is held accountable to getting that information to the proper reporting structure. You can go to the next slide, Emily. So we wanted to show just some simple examples of some scorecards that we have seen at some of the hospitals where we have worked. So this is an example of a hospital who really wanted to report progress on their communication board. So these were up on the nursing units. And as you can see, they had a medical unit, a large medical unit, large surgical unit, ICU, and then they had environmental services as well as the management metrics that they were looking at. And they really wanted to focus on their discharge processes because that's where they were having problems. So you can see the indicators go to the discharge process, such as discharge within 2 hours of the order, which is best practice. Once you receive that physician order, you should have the patient moved and out of the building within 120 minutes. Percentages of discharges by 11 a.m. Now that can be individualized to your particular hospital. Because the spike of admissions at this hospital was happening about 1 to 2 o'clock in the afternoon, they wanted to make sure that they had as many of their discharges out by 11 a.m. And then we had transfer turnaround time because they wanted to make sure that patients that are moving between units were transferred timely. If you go down to the EVS indicators, you can see bed cleaning turnaround time for regular cleans and then for stat cleans. And then perhaps one of the most important metrics that this hospital wanted to look at was, were they denying anybody that could have services at their hospital? So they looked at the times that they had to deny direct admit and the occurrences that they weren't able to add on in another OR surgery. Because that was turning patients away from their hospital and wasn't meeting their mission. So that's how these indicators were arrived at. So as you can see, it's a very simple red, yellow, green format. So red, like a stop sign, is we're not meeting the indicator. Yellow means they're improving, but they haven't quite met the indicator, and green means that they have achieved the indicator. So as you can see at a glance, when you have this up on a communication board, you can see how things are progressing. And if you have one unit doing something, better than the other, it's a little healthy competition, but also allows for the people on those work teams to share the strategies that they're using. If you move to the next slide, we'll show another example of a scorecard. So on the last slide, we showed many metrics on one scorecard. This is just an example of looking at one particular metric, but trending the progress month over month. So this is a medical unit and their discharge orders by 11 a.m. Again, that all depends on the flow of the patients in your hospital, and in particular, when you get your spike of admissions, of when you really need to determine when you set your discharge order time and your actual patient exit time. So you can see in January, 43% of the orders were placed before 11 a.m., not too bad. You can see the trend line at the bottom trending up, but about 4 months into the project, it was 49%. So we show this example because we don't want anybody to get frustrated with the pace of a patient throughput project. This is some moderate improvement that's happening, but oftentimes it's hard to move these indicators. There's a lot of things that go into a successful patient throughput project, and you must get in physician involvement to move a lot of these indicators. So if you move to the next slide, we'll show another example of how to show physician indicators and really get them engaged in the process. So this is a blinded example of discharge order writing. So this particular hospital wanted their discharge orders written before noon. So you can see Dr. 11 wrote 86% of his discharge orders, his or her discharge orders before noon, while Dr. number 9 on the other end only had 20%. So again, this speaks to a little healthy competition, but it also allows you to see what the practice patterns are from the higher performing physicians and what they might be doing differently than some of their colleagues. So it's good to do this comparison, and I know we've worked with hospitals that totally unblind this data too and put names to each of these percentages, so you know which hospital or provider is providing this type of service. You can move to the next slide, Emily. Thank you. And to take it a step further, This takes hospitalist teams, which many of your organizations probably have, and compares hospital teams to each other. So not just on that discharge order time that we showed in the last slide, but this shows some various things. And this really goes back to the beginning of the presentation, where I talked about the financial benefit of installing a throughput project in your organization. This actually shows each hospitalist team the impact they can have on the organization. So it shows all the discharges, the case mix index, which is important because some teams are taking care of more complex patients than others. You have your percentage of one-day stays. Medical necessity and level of care is something that we're always focused on, and we want to make sure that patients are in that correct category. So that's something that it's good to keep an eye on. You have your average length of stay against your expected length of stay. And then those potential avoidable dollars, again, are calculated by taking the average length of stay minus the expected length of stay and getting the amount of excess days, or those days that the patients are staying above their geometric mean. And it's also important from a quality perspective to keep an eye on, of course, your 30-day readmission. So that's indicated on the scorecard. So again, just another example of how you can compare hospitalist teams to one another and get them involved in the engagement. And again, want to emphasize that you need to sit down, explain this very thoroughly to all of the hospitalists, as well as show them the sources of the data and validate that data prior to publishing any of this. Next slide.
Thank you, Barbara. So you touched briefly on some of the financial benefits, but I'm interested in hearing kind of a bigger picture here. What are some examples of benefits of an effective throughput program? And Barbara, I'll let you take that one first.
Okay. There are many benefits to a throughput program. There's financial benefits, of course, like we talked about, but also benefits to quality and service measures. But perhaps the best way to explain the benefits of a program is through some real-life examples of hospitals who have implemented an organized throughput program. So on this slide, you'll see the impacts of these efforts. This is a system with 2 community hospitals up in the Northeast. They were very much struggling with throughput and patient access, and they were diverting patients out of their ED quite frequently, and also had a length of stay that was significantly above the geometric mean. So they engaged us to help them with a comprehensive throughput approach. So some of those things that they did included a care management redesign from the point of entry, including that medical necessity determination, ED case management, and intense case management education and training. Secondly, we help them with a comprehensive inpatient and ED throughput strategy, including putting in coordinated interdisciplinary care rounds, looking at nurse-to-nurse handoffs, bed management strategies, and the implementation of a bed management board. And then also looking at those patients, outpatients in a bed, that sometimes clog up your system because it's not necessary for them to have that level of care. And we help them redesign how those patients would be cared for. Lastly, and probably one of the most important parts of this engagement, was the hospitalist redesign. So we worked with a hospitalist program to look at the schedules and align the hospital assignments for optimal patient care, but also for optimal patient flow. And we also helped them redesign their incentives. So the hospitalist incentives were aligned with the hospital's incentives. So you can see the results of this project. They resulted in over $1.5 million of financial benefit. They were able to reduce their length of stay, and their trend is staying below the geometric mean on a consistent basis. And perhaps the greatest gain was the reduction of the excess days. So you can see that there was a point where they spiked a little bit, but then quickly rebounded and put strategies in place to reduce those excess days. And we always keep in touch with these hospitals afterwards, and they have been maintaining their length of stay as well as their excess day reduction. So this is just one example. On the next slide, Bonnie will talk through a different example for the group.
This example is also a two hospital system in the state of New York. Together, they had about 500 beds. One hospital was a bit smaller than the other at about 150 beds, the other one at about 350. One of the issues they both shared, though, was that the ED both had left without being seen rates of nearly 4%. And it was for different reasons at each hospital, with different patient populations, but nonetheless, it was still unacceptable. So the work teams at each hospital analyzed the issue and determined that the late discharge was a driving factor. The data on the slide on the left was taken from an average of the physician's discharge time, and we averaged them by week when they were working, mainly the hospitalist physicians. The baseline shows that the hospitalist on that slide on the left shows that the processing time and the nursing time was very late and allowed for late afternoon discharges. Especially for this hospital, when you see physician A, B, C, D, all of them, the housekeeping staff left at 3 o'clock, 3:30. So basically all the beds were emptied when the housekeeping staff had left the premises, and there was something like 2 housekeepers left in each of the hospitals. So we worked with the data on what was driving these late discharges, and we saw that nursing on the nursing side, there was duplication of nursing work, processing, documentation, as well as not knowing a day before when those patients were leaving so we could start working with the discharge the night before. Secondly, the physicians often made rounds late and did not appreciate the fact that early discharge equals more time for them to work in the afternoon and get those patients in. So the chart on the right illustrates the discharge completion at around 2 o'clock. So there was marked improvement. As Barbara said, we blinded the physicians here, but physician's identity here. But as this project progressed, we no longer blind them, but we put the actual name. And this seemed, the competition to do better seemed to heighten the ability to want to work towards that goal. Particularly if you look at physician C, he improved his discharge rate from writing orders at 2:15 to 12:15. And with our nursing process improvement, you can see that those patients were processed in less than 2 hours and were out of the hospital by 2 o'clock. I will add, we also did change the housekeeper schedule to accommodate bed cleans. So we were able to create those vacant beds on the inpatient unit right around the time that PACU is starting to send their surgical patients, and the emergency department admissions were really starting to pick up as they do late in the afternoon. Overall, they were both able to, over time, as Barbara mentioned before, over time with about 6 to 9 months of work, bring down their left without being seen rate to less than 1%. Okay, Emily, next slide.
Thank you so much, Bonnie and Barbara. That was a fantastic presentation. We will now begin today's question and answer session. As a reminder to our audience, you can submit your questions by typing them into the control panel in the space labeled "Enter a Question for Staff" and clicking Send. We will try to get through as many questions as we have time for, and it looks like we have a lot of great questions rolling in. Our first question from the audience is about the early discharge order requirement. This is an interesting question. Bonnie or Barbara, how do you handle providers that will hold a discharge until the next day to meet the early discharge order requirement?
We allowed for, I can answer that question. We allowed for a certain percentage of discharges to be late in the afternoon, because that was a great question, because the last thing you want is someone to hold a patient overnight, increasing the excess days or not vacating that bed. So we allowed for a certain percentage, and I want to say for the most part it's like 10% for discharge after 2 o'clock in the afternoon.
Okay, thank you. So our next audience member would like to know, what are the key metrics or measurements to track for throughput optimization? And Barbara, this may be a good one for you.
Sure. So we mentioned some of those in the presentation, such as discharge order time, length of stay, bed turnaround time. But you can also specifically look at some processing time within your EDs. So that, particularly that end segment of from the time that the provider has a disposition until the patient exits the ED and goes into an inpatient unit. That's oftentimes where we see a lot of opportunity for improvement. So that's a good one also to measure. As related to other parts of the organization, like the PACU, you can measure that as well from the time that the patient is medically cleared to leave the PACU until they're up into their destination unit or in their bed. If you're having problems with the transfer of patients to multiple units, that's another thing that you can look at, is the number of times that a patient is transferred within the same level of care, because every time you hand off a patient, it's not only more work for nursing staff, environmental service, transportation, all of that, but it also increases the chances of mistakes with every handoff that you have. So that's another indicator that you could look at, is on average, how many transfers within the same level of care, and decreasing that number. So those are a few other examples of indicators.
Thank you, Barbara. Our next question from the audience: how did you get the physician engaged in the committee work to help improve this process?
I can answer that. First, we started at the top. We worked with the chief hospitalist and they were actually, in many cases, they're anxious to participate because sometimes they feel they're not appreciated for the work they do. We also encourage them that we would take into consideration, or we would address some of the issues that they have, that they experience on a daily basis that decrease their ability to discharge patients. Top of that is consults. Second one is not having kind of ancillary or testing services available. In one instance, for example, their big concern were getting MRIs completed on a patient that were in the inpatient setting. So we created an algorithm with the radiology director, physician director, as well as the hospitalist, and how we're going to prioritize some of those testing. So making sure that there's something in there for them, and that we are taking their concerns and some of the barriers that they face on a daily basis that are really frustrating them very seriously. So that was one way. And then another way is we did, one hospital we worked with, the anesthesiologist, I think, called me at home one evening and said, I can't wait to be in your committee because I'm so frustrated. So tapping into some of those attendings, emergency room physicians and the anesthesiologists who've had some long-standing frustrations with the process, and giving them a forum to express those frustrations and then work positively is another way to get physicians to be engaged. We've not had overall a tremendous issue with getting physicians engaged.
Thank you, Bonnie. I can see how those committees really work as forums for physicians. So our next question is a great question from an audience member. Can you speak to the disconnect of census data and true capacity, and how to help hospitals understand they may in fact need some changes to address throughput?
Sure. So yeah, that's always a struggle, because usually census data is done, on midnight census, and it doesn't actually show the true capacity of the nursing units if you don't have a head in a bed at midnight. So ways to do that are just really looking at the admission discharge pattern, and you can even drill it down to by nursing unit, and when the patients are coming and going and transferring by time of day. That way, when you lay that against the number of beds available, that it's a little bit more clear of the processes and when the bottlenecks are occurring. So bringing that type of drill down information in front of the leadership, and that's why it's important to have leadership on these work groups and get them to understand that, you know, it's not always just head in a bed census data at midnight for looking at throughput. So that's an example of how you can do that. And then the other factor that we see a lot is, you know, the number of physical beds versus staffed beds. And we all know, I know many of you probably have a lot of staffing shortages out there. We're seeing it everywhere. So being really creative on how you utilize, you know, all the members of your healthcare team to care for your patients will be important. And so understanding the staff beds versus the actual beds. And then again, flowing out really the activities of the unit and when the unit meets max capacity. So for example, if you have max capacity happening at 3 o'clock, you may need to move back your discharge time to much earlier in the day, so you have those patients, so those beds cleaned and available for when your max census tends to hit. So I hope that helps.
Yes, that was very informative. Thank you, Barbara. So we have an audience member here who says, interdisciplinary rounding definitely is one of the cornerstones for improvement in inpatient throughput, but the logistics of instituting that seem almost impossible, especially in hospitals with non-geographical patient units. So what are some strategies, in your opinion, to help improve engagement from physicians and nurses who are already time constrained? And I know we may have touched on this, but if you would like to expand on those strategies, that would be great.
Sure, I can take that question. I totally agree with the person who submitted the question. Hospitalists are not usually enthusiastic about geographically assigned assignments, so it becomes a time constraint. We've tried a number of things, including morning huddles, where we stage the huddles short. We'll have a short 15-minute huddle and just talk about the patients that are being discharged and what are the barriers for them to being discharged that day. And we will do that sometimes by phone. We've done some teleconferencing. We've also used something like what we're using right now with the webinar, but Skype. So everyone can be on the phone and we can quickly go through the patients. Oftentimes we'll organize the patients by physicians and try to get their patients, one hospitalist or one physician's patients done first. But I agree with you, it's a challenge, but it tends to dissipate a little bit once there's a commitment that and some outcomes that you actually see patients do get discharged, and we actually overall save time by not tying them up all day making multiple phone calls.
Thank you, Bonnie. That was very helpful. So for our next question, what is the typical timeline from the beginning to seeing results for an initiative in this area? And Barbara, I'll let you take that one.
Sure. Well, it depends on really what indicator you're looking at for results. So that's what can be kind of frustrating sometimes with a patient throughput project, because when you look ultimately at the financial benefit and length of stay, that can take a longer amount of time just by the nature of how long it takes to impact length of stay. So I'd say within about 5 to 6 months, you should be able to see an impact on your actual length of stay and see financial benefit. However, there's other indicators that you can see quick results in, and that's what kind of keeps the teams going. So some of the examples that we had talked about before about, moving those discharge times a little bit earlier, or reducing the time it takes to turn around a bed, or getting patients transferred from one level of care to another level of care more quickly. So those types of indicators, if you put specific initiatives around them, you can move the needle quicker on those, and that keeps the teams more engaged and going. But you should really, particularly if you're going to build some financial benefit into your budget, allow for a period of about 6 months to see financial benefit hitting because of the comprehensive nature of all the initiatives and what it takes to move the needle on length of stay.
Perfect. Thank you so much, Barbara. It looks like we just have time for one more question. So our last question from the audience is about data integrity. This audience member says, data integrity seems to be a big issue. What are some methods you use for data validation?
I can answer that question. We clean our sources. I mean, we start with the data source, and we recognize some of the limitations of some of the source and some of the data we get. It may be that, and then we work with our committees and our groups to be able to read and interpret that data correctly. We like to have our data as quickly as possible, so at times we'll design our own spreadsheets to do that. But if we're working on and using data that is furnished to us by admitting and finance, RevCycle, things like that, we will we'll postpone that and take monthly data, and we use the monthly data to validate our weekly data. Ask the questions: does this make sense? How was this gathered? What are some of the differences in the data, and why would that be? So you're right, data integrity is a constant challenge, but we find that by comparing data along the way and working closely with our data providers over time. And when Barbara was talking about 6 months of work, it sometimes takes us almost 3 to 4 months just to get the data that people believe in it and that the integrity is of an acceptable level. Thank you.
Thanks so much, Bonnie. And that's all the time we have today. I would like to thank Bonnie and Barbara for their excellent presentation and to our audience for participating. Please enjoy the rest of your day, and we look forward to having you join us for future webinars.